The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, a hard trek to IT systems.
This is where that really important concept of change management comes in.
That's Dr Oliver Daly, a consultant urogynaecologist and clinical informatician. He is a Safer Care Victoria Academy member focused on clinical informatics workflows and was previously the Director of Medical Services at Mercy Health Australia and Chief Medical Informatics Officer at Western Health. And I'm presenting him with a difficult scenario.
So you're going to ask us to do things differently, and that automatically brings up resistance, fear of loss, all those sorts of things.
In today's scenario, the board has recently approved a major investment in a new medication management computer application. At the moment, all medication management in the hospital is currently paper-based. The business case suggests that this will dramatically reduce medication errors and enable the hospital to track and reduce the inappropriate prescribing of high-cost medications. Antibiotic stewardship is also expected to improve, resulting in more effective treatment of infections. These benefits are projected to meet the cost of implementation over a 3-year period. The selection of the computer application was largely driven by the IT department focusing on its ability to integrate into the existing patient management system. There was some, though limited, involvement of the medical and nursing staff, although they have been promoting the benefits of computerised medication management for many years. This is a huge topic, so I started by asking Oliver what big issues this scenario raises.
My background is 25 years of working in IT-related roles, everything from system administration to developing web apps to as a Chief Medical Informatics Officer and governance levels. This is a really common problem, and the key thing we need to do is whatever money that we put into these investments, we need to see the return on that. So it's not that we shouldn't be doing this, it's actually what is the best process so that we actually deliver the outcomes of better patient care and supporting clinicians in doing that. It's very costly to put these systems in. We want to make sure that they work. It's not just a standalone system. It actually has to integrate with all of the other clinical information systems that we deal with currently, but also in the future, so that it's something you can future-proof and continue developing that product to continue to meet the needs of the organisation. It would be really interesting to know what information the board was acting on when they made this choice. The red flags in this situation, I guess, are the limited engagement with clinicians. I think one of the challenges and one of the elements that organisations fear is that clinicians will ask for too much. And they'll say, but we can't possibly meet every need that you have, and therefore there'll be cost blowouts, and that's going to really threaten the project. The other big red flag is the return on investment, that we're going to cover the costs of this project in a 3-year time period, when we know the return on investment for big IT projects is about 10 years. Have they included not just the cost of procuring the licenses and managing the project and the IT resources, have they actually covered what is the real costs to the organisation, which is actually the ongoing business as usual maintenance costs and developing the product, but also what is the cost to clinicians' time going forward, given that, 70% of hospital costs are salaries?
You've mentioned clinicians a number of times, Oliver. Often, I guess at the board level or at the IT level, they think it's a doctor thing because doctor prescribe medication. But there's a lot of other staff involved. There's the junior medical staff. There's the nurses who dispense the medication. There's the pharmacists. And then you've got all, infection control, quality and audit. And how do you ensure that each of these different groups are comfortable with the board's decision and the applications?
This is where that really important concept of change management comes in. And, sort of Kotter's approach to this is actually establishing the burning platform. This is why we need to change. So the junior doctors would say, I really don't like having to rewrite a drug chart every week. The nurses and the pharmacists will say, I'm really tired of not being able to read the doctor's handwriting, using inappropriate abbreviations that actually lead to medication errors. There is a really strong evidence base for the benefit of electronic management systems, and it's actually using the experiences of the clinical staff as part of your solution to say, these are the problems that this system is going to help solve for you, as opposed to getting to the really difficult bit, which is the barriers. So you're going to ask us to do things differently, and that automatically brings up resistance, fear of loss, all those sorts of things. So it's really applying a change management model, which I think, as we know, about 70% of these sort of projects fail because of failures in change management. Yeah. So I think that's the really important aspect of getting the clinicians in early. Now, in this scenario, what you would have hoped happened was that there was organisational transparency. We are going down this path. We want to get you involved early so that we can get the functional brief. What does this system need to do for you? But also by saying, here are the constraints. There are certain things that the system won't be able to do, so that you actually have a functional brief upon which, so you've got a firm basis for the business case. It's actually not going to deliver just the financial and technical outcomes. It's actually going to deliver the clinical outcomes for, ultimately, health service performance.
Moving to an electronic system can be extraordinarily challenging, particularly with staff. Some are computer natives and others don't actively avoid using computers, and yet medication management is so integral to patient care. Even before you start training on the specific application, how do you bring staff up to being comfortable with computer systems?
I think it's really identifying those who are struggling, and I'd be using your clinical leadership to identify those groups. It does start with basic computer literacy. This is something that the Australian Digital Health Agency, the Australian government has identified, that we need to lift the digital capability of the health workforce. I think other technical solutions like single sign-on, so that it actually takes away some of the barriers to being able to access the system. So having a very holistic workflow-based approach. And then I guess it's also looking at the culture of the organisation.
So that brings us to training. Training's a huge impost that's often undervalued. If you've got hundreds and perhaps thousands of staff, getting all of them to be trained on the new system, particularly when many of your medical staff may well be not salaried doctors, so the training comes at their cost. How do you organise this massive training exercise?
I think it's considering what are the training needs, so identifying the pinch points. I guess there's pinch points from using the system, but there's also the safety aspects. So the key deliverable for, I would say, an electronic medication management system is improving medication safety. So how to use the system to ensure those safety benefits are delivered. And so that requires designing the training packages, also identifying what are the training opportunities for each of the cohorts. So often nurses and midwives will have double staffing time to be able to do this. In a couple of the rollouts, we would use clinical handover to really provide these short, sharp, punchy messages about here's the priority message for the week. So how do we deliver this in a way that the clinician can do it on their own terms and in their available time, recognising that is this a mandatory training requirement? Of course, that's going to have a cost impost on the organisation because you've got to pay for that training. So it's making sure that it's really cut down to small bite-sized chunks as well. So it's really difficult to do a half an hour long module because you get interrupted. Also recognising that there are people who go between different areas in the hospital. So it really requires the expertise that clinical leadership and management in hospitals have to design the sort of reports that they need so that then they can act in a real time on that feedback and address those training deficits early.
My experience is that flexibility is an anathema to the training personnel. You have to do the 2-hour step-by-step module or you're not trained. And yet many staff, nurses and medical staff, just want the 10 minutes on how do I get in, how do I get out.
How do I do my job using the system?
Yeah.
And I mean, I can use one anecdote. So one of the organisations I worked in, we were bringing in an infusions module for the particular vendor. And there were 7 aspects to it, everything from basic fluids through to total parental nutrition and warfarin or heparin. And there was a real fear that, wow, this is going to be really costly and time-consuming to get everybody to do every package. And then we had a moment of inspiration. We said, well, why does every staff member have to do the same training? And actually, we were able to identify tiers of training where those who work in an intensive care environment, they're going to have to know everything about every form of medication that can be administered through this system. Whereas if you have a visiting medical officer who comes through who they don't do ward rounds, they could just do the one basic module. They didn't have to do all 7. So I think that comes to the essence of the flexibility. It's not just about the method, but actually what do they need to know to do their job. Yeah.
One of the challenges for leaders is to create incentives, carrots rather than sticks. So often these large projects end up full of sticks, trying to get all the laggards to comply with their training. What sort of incentives can you create for the implementation of a change like this?
Well, number one is taking away the barriers. That's what stops somebody from doing the training. But also we're looking at where are the opportunities to provide the training in their allowable time. So, for example, if you do have somebody who's on a sessional basis, you might see patients for 3 hours, but that half an hour at the end will just get you to do this training. Where is the opportunity for the staff to complete this training? And it's usually not I think there's this expectation, particularly from the training staff, they just don't want to do the training. Yeah. But actually, I don't think that's what it is. It is actually saying, well, no, they do want to feel competent. As health professionals, we all want to feel good at our job. And it's actually what's the quickest path to getting the core skills that we need.
I think it comes back to, as you said earlier, Cotter's first principle, create the burning platform. And I'm suspect so often in scenarios like this, we as leaders don't do a good job at creating the burning platform. So actually looking at the data and the patient harm that's inherent in the current system and what might be eliminated.
I think on that point, the Commission has come up with a fantastic set of guidelines on the implementation of electronic medical management systems that covers absolutely every aspect of building the business case, engaging, making sure it meets the standards. So I think that's using the resources that are out there, and I think this is probably what the clinical leadership to know, that they don't have to reinvent the wheel every single time they do this. There is fantastic evidence for the benefits of this, and it's actually relatively easy to have the rationale that you can present to your staff about these are the benefits in the long term.
Every new computer system is promised to save the hospital enormous amounts of money, improve quality, eliminate errors, and yet looking back 5 years after implementation, it's very hard to actually demonstrate that the implementation of an electronic medication management system makes a lot of difference. Why is there such a disparity between the promises and the deliverables?
I think you hit the nail on the head earlier when you talked about the future scoping. How do you anticipate the future cost of the organisation? But what it really requires is a whole of life cycle approach to this. I was mentioning the staff cost. If you've got a system that actually means that clinicians are spending more time in front of the computer than with patients, then we're actually not delivering the value-based healthcare. So there needs to be a way of factoring that into this. Often the costs are broken down into the things that are easy to quantify, which is the project management, the licensing, and the project management costs. But we probably need better methodologies across the board for any digital transformation project about this is how you estimate the lifetime costs of implementing this system.
With medication management systems in particular, it's very easy to put in alerts. Doctors can find those extraordinarily annoying and often just ignore them and blast through them so they're not helpful. Can you talk to us about the balance between avoiding harm and annoying the doctors?
Yeah. So healthcare organisations are the most complex organisations on the planet. There's this notion that, I put this system in and this will actually tell the clinicians what to do, as though every clinical situation has a defined pathway that A goes to B, goes to C, and that's rarely the case. I can write a rule that alerts somebody if I do this, but how does the person respond to that, the human factors aspect? And then what are the processes around that? Because you can create perverse incentives by trying to constrain people's activity and also not having trust. A really key premise is the system should not prevent a clinician from doing something. There will be rare exceptions to that. But some amazing work that was done in one of my previous organisations by one of my colleagues was using some of the reports of the alerts, so possibly we can click and track and these sorts of things, looking at, how often did the alert result in a change in the action of the clinician? And the general rule is about 70 to 80% of the time when an alert is generated, it should result in a change in behaviour. That means you've met a good threshold.
I think it brings up co-design as well. If you ask the clinicians what alerts would be helpful, get a very different response from asking an IT technician what alerts are possible.
Yeah.
We've already talked a little bit about outcome measurement, but from a clinical governance perspective, what outcome measures would you build into a system like this to demonstrate that it's working?
I would use the existing indicators, embed the existing indicators of health system performance into the system rather than creating a whole lot of new metrics, because once again, you want to use a metric that hopefully improves performance, doesn't add additional burden to clinicians. So I think the more that we can link it to, safety and quality indicators.
I think that's absolutely right. You need to engage the people who assess the outcomes, not the technicians, in determining your outcome measurement. Any final thoughts or observations on a scenario like this? It is so common, and it's the bane of many of our lives as medical administrators.
Look, I think what it shows is we've put medical leadership and management in a really invidious position that we haven't really given them the skill set of that. Because there's the technical aspects of health information systems at a broad level, but then there's where really leadership and management comes to the fore, which is change management, and how do we help the workforce to provide better care? How do we provide medical leadership with the knowledge, the skills and experiential opportunities so that they can be at the top table with the executive when these decisions are made to say, actually, I think you need to talk about these other people, particularly because the clinical leadership are often, they're leading all of the hospital governance. They really need to go out, here are the people who should actually be not just consulted or informed, but actually they actually have responsibility and accountability for the outcomes of a clinical information system. So I think that's the work that we have to do over the next few years.
That was Dr Oliver Daly, a consultant urogynaecologist and clinical informatician. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.